Good morning, good afternoon, and good evening. Welcome all of you to this live program at Orthopaedic Principles. Today, our guest of honor is Dr. Nirav Pandya from California, United States. Dr. Pandya is a pediatric orthopedic surgeon and sports medicine specialist within the UCSF, Department of Orthopedic Surgery. He's also the section chief of the Division of Pediatric Orthopedics. Originally from Chicago, Dr. Pandya received his undergraduate degree from the University of Chicago. Dr. Pandya then went on to complete his orthopedic surgery residency at the Hospital for the University of Pennsylvania in Philadelphia. He then completed a fellowship in pediatric orthopedic surgery at the Rady Children's Hospital in San Diego. Dr. Pandya has authored over 60 peer-reviewed publications and multiple book chapters, and he speaks regularly at national and international events. If you've noticed, Dr. Pandya has delivered another lecture on our channel before, and today it's my great honor to bring back Dr. Nirav Pandya for this wonderful live program. Over to you, Nirav.
Great, thank you for having me. And today I'll be switching topics a little bit. I talked about ACL last time, and today what we'll be talking about is special considerations for the management of the pediatric polytrauma patient. And I think this is an important topic because a lot of times we're very comfortable with dealing with adult polytrauma patients, but pediatric patients can be a little bit more different, particularly with some of the principles that we have, both from a physiologic standpoint as well as a fixation standpoint. So the goals of this talk will be the following. Number one, we'll talk about the epidemiology of pediatric polytrauma, which I think is important to understand how trauma patterns have been changing. We'll talk about initial assessment differences, some physiologic differences, which is really the key part of the talk. We'll talk about timing of fixation and then some management pearls. So if we look at, within the United States, if we look at the data, there was this article that was done in the Journal of Pediatrics, and they found that actually nearly 60% of all pediatric deaths are actually trauma related, which is a large percentage of deaths. So it's something that we really need to consider and understand when these patients come in, and if they are able to make it, to understand how we treat them. These trauma deaths are more than sudden infant death syndrome, more than cancer, and more than infection. 1 in 4 children will be victims of trauma at some point during their life. And there's a tremendous cost to the healthcare system. And in the United States, it's $81 billion per year, and that's increasing. Obviously, that's been changed by COVID, but in general, this is something that is a very high, tremendous cost to the healthcare system. And what we're seeing in general are more multiply injured, critically ill children. There's increased participation in high velocity activities. They're more likely to suffer adult type pattern trauma. And if we actually look at what is happening in terms of the organ system injury in these kids who get it, it's a little bit different than adults. They have about a good percentage of abdominal injuries. These kids will have 8 to 27% of kids who present with trauma will have abdominal injuries. They'll have thoracic injuries about 5 to 12% of the time, and they'll have GU injuries 9 to 24% of the time. So it's important to understand that these kids, even though they may not have necessarily symptoms as an adult patient will, they will have these other multi-system injuries. But the most important thing to remember is that neurologic injury in this pediatric polytrauma patient is most important. Most kids will have a closed head injury in some form or fashion who do have some degree of neurologic injury. And the death in pediatric patients is correlated with this traumatic brain injury. And there's a 30% risk of residual neurologic deficit after polytrauma, which is important to note. So a lot of times what drives the pediatric polytrauma patient and then how we as orthopedic surgeons play a role is dealing a lot with neurosurgery. In adults, it'll be very different. It could be more in the general surgery trauma surgeons who are dealing with multi-system kind of chest cavity injuries. In pediatric patients, it's going to be the neurologic injury. Now, a lot of people ask, why should we care? These are a lot of different, non-orthopedic issues, but I think due to the fact that we will be more aggressive in fixing these patients and they're more likely to live after these severe polytrauma events, it's important to understand how our orthopedic fixation fits in with these general surgery / trauma principles. And there was this great study actually years ago done by Randy Loader, who looked at the pediatric polytrauma patient when he was in Ohio. And he actually found that 76% of pediatric patients have orthopedic injuries after polytrauma. And that's the really important point, is that even though, there are, multiple patients, they have multiple other organ system injuries, the fact that a lot of them will have orthopedic injuries means that we're going to be intimately involved in the care of these patients. And it's important to understand the principles of taking care of them. Now, a key point is that children are not small adults. So it's important to understand that we're not just taking our adult principles and then bringing them over to our pediatric patients. It's important to understand that we have to utilize different principles. Now, it's important to understand where these kids are treated is extremely important. And there was a study that actually looked at pediatric patients who are taken care of at adult level trauma centers. And there's a huge review of the National Trauma Data Bank base. And they found that in patients under 18 years of age, they had about 53,000 children. And they looked at mortality, whether these kids who were severely injured went to an adult versus a pediatric trauma center. The overall mortality was 3.9%, and the odds of mortality was actually 20% less at a pediatric trauma center, which is important to note. But at the same token, even though these kids do better at a pediatric trauma center because they're pediatric trained intensivists who can take care of their multi-system injuries, we as orthopedic surgeons shouldn't blindly apply pediatric principles to these polytrauma patients. So we shouldn't take a kid and necessarily just cast them, treat them non-operatively. We may have to change our fixation paradigm for these kids due to the type of the injuries that they have and the things that we may be seeing. So this is an example of a patient who, potentially could be a pediatric polytrauma patient, has a closed femoral shaft fracture, an open type 3 tibia fracture, and an open both bone forearm fracture, and a lung injury. Okay, so the question becomes, how do you put that all together? I think in the adult literature, we have a very strong algorithm for how we do this, but in pediatrics, we get these severe patients and then we have these severe injuries, and we're still trying to figure out how do we fix these patients, and I'll hopefully give you some principles today. Now, the reason why this has happened is not a fault of anyone. It's just that orthopedic attention in the pediatric orthopedic community has lagged behind this. I mean, if you look at supracondylar humerus fractures, and even now, this is probably more, you have hundreds of papers, and there are hundreds of papers about medial versus lateral pinion, et cetera. You've got tons of papers on lateral condyle fractures, medial epicondyle fractures, tibial shaft fractures, femoral nailing, pelvic fractures, but there's very little on pediatric polytrauma patients and from a pediatric perspective in orthopedics. So I think it's important to understand the literature and to combine these together in order to better understand the management of these patients. Now, these next couple of slides are probably some of the most important in terms of understanding how pediatric polytrauma patients actually differ from adult patients. So number one, the first thing is that children do not develop hypotension until 25% of the blood volume is lost. So you have to rely on heart rate, not blood pressure, to know if they're actually hypotensive. Okay. Key number one is that rely on heart rate. So if you see tachycardia, get worried. They may actually have a normal blood pressure and be tachycardic, so that can be an indicator of blood loss. Number two, children have larger head and smaller neck. So you want to use an occipital cutout or elevated mattress when you're stabilizing these patients in the field, so as to not cause spinal cord injury. Number three, the cervical spine is more flexible in pediatric patients. So you can have a spinal cord injury without any radiographic abnormality. And therefore you need to make sure that you're assessing these patients and not suddenly clearing them until you have the actual appropriate imaging. Number four is that when patients do come in and have to be temporarily stabilized, you cannot put traction pins in the proximal tibia. They should be in the distal femur away from the physis, because what can happen is if you put a traction pin in the proximal tibia, you can close it, the proximal tibial physis and cause recurvatum. So once again, you have to place your traction pins if you're using them in different locations. And then we have to look globally at what do we know about orthopedic intervention in the polytrauma patient? What do you know about the physiology? Because hand in hand, even though these principles, it's appropriate for us to plan our fixation in the context of their physiology. And a lot of times you may be working with the general surgeons or the neurosurgeons, and it may be a team decision as to when's the best appropriate time for fixation. And the adult principles of this systemically are very different than the pediatric population. Okay, and there's very little we know about it, but we do know a lot about the physiology, and then we can apply those principles. So we obviously know that there's a large cascade in terms of the inflammatory response, both a systemic and a local inflammatory response, which drives when it's appropriate to actually perform fixation in the context of their multi-system injury. So number one, when we look at organ failure in adults occurs 48 to 72 hours after injury. Okay, so unlike pediatric patients where it occurs immediately after injury. So when we talk about quote unquote damage control orthopedics in adults, where we say, look, we don't do anything definitive for them because the systemic hit's going to happen 2 to 3 days later. In kids is a little bit different. That systemic response, that physiologic hit is going to occur immediately after injury, which can then subsequently then affect how and when we're actually going to treat these patients. If we look at organ failure, it occurs sequentially in adults, whereas in kids, it occurs simultaneously. So that's important to note as well, too, whereas with adults, we're waiting for the lungs and then the GI system, et cetera, to kind of sequentially go. In kids, it's going to happen all at once. So that's important to note in terms of timing your fixation. And multi-system failure in general is less likely to occur in children and more so in adults. So once again, that's an important thing to consider, that even though a child may be very, very sick initially, you can say, look, maybe we do need to plan for that fixation tomorrow because we know that child is going to be better, particularly if the other surgeons or teams are able to clear the patient. Another big factor in terms of how kids will be treated is acute lung injury. Now, there's a very high risk of acute lung injury in adults, but it's a very low risk in children. In terms of a systemic inflammatory response, is very robust in adults. That's why they get this multi-system huge response, and we sometimes need to wait 48 to 72 hours before placing fixation in a femur or tibia or fixing a pelvis, because we don't want them to get sick. In kids, the systemic inflammatory response is very dampened, so potentially that's one factor that shouldn't hold you back from actually fixing these patients. In terms of the local inflammatory response, it's dampened in adults. Okay, but it's very robust in children, and I think that's important to note, is that that local inflammatory response allows for an extensive amount of tissue repair at the local level without the systemic side effects. So someone who may have a fracture, very severe open fracture, or very severe soft tissue injury is more likely to heal this in the pediatric population in the context of polytrauma, unlike an adult patient where you may be deciding what and what not to fix based on the systemic inflammatory response. And then this is obviously a very excellent point for children in terms of morbidity and mortality, that in terms of adults, where the mortality comes from is from the pelvic fracture, it's from the bleeding that occurs from the pelvic fracture. But in kids, the morbidity and mortality occurs from the solid organ injury, okay? And the reason why that's important is that in the adult population, fixation of that pelvic fracture becomes that much more critical to prevent bleeding and other complications that can happen from polytrauma. In kids, it's the solid organ injury that's going to lead to morbidity and mortality. So from a critical standpoint, the general surgeons, the neurosurgeons play a critical role in decreasing morbidity and mortality, while we as orthopedic surgeons provide fixation so that that can allow kids to mobilize and not have the complications from prolonged immobilization. Also important to note, and this is key, particularly when kids come in initially, there's a higher rate of recovery from neurologic injury in children than adults. And the reason why that's important is a lot of times pediatric patients will come in with a very severe traumatic brain injury. They will not be clear for 2 to 3 days. And they may have acetabular fractures. They may have severe knee injuries. They may have femoral shaft fractures. And sometimes, the orthopedic team will say, well, look, this patient has a very severe brain injury. They may not necessarily make it, or they're going to have severe sequela. It is amazing how much kids will survive and turn around from very severe neurologic injuries. So once again, in an adult patient, they may not be willing to take the risk to fix these various injuries because of the severe neurologic injury. In pediatric patients, because they can turn around so quickly, we need to be just as aggressive in fixation. Also, because if these kids are going to make it, if you're waiting 2 to 3 weeks to fix them because of these injuries, they may heal in a deformed position and may need subsequent intervention down the road. So the timing of fixation in this population really suggests that because of these physiologic differences, it suggests immediate rather than delayed fixation, which I think is critical, is that unlike the adult population, you can be a little bit more aggressive in terms of fixing these kids when they come in. And this timing of fixation was shown in further studies by Randy Loader, which showed, this was one of his studies that looked at 78 polytrauma patients, and they looked at immediate surgical stabilization versus greater than 72 hours. And what they actually found with the patients who were immediately fixed had earlier mobilization. It was able to facilitate wound care more. It minimized cast complications. It decreased systemic complications, and they were able to be more aggressive in their fixation. So once again, the outcomes were better in polytrauma patients when you were fixing them early as opposed to later. And kids recover. And I think that's the most important factor. Okay. This is another study that was done by Dr. Loader as well too. He looked at 93 polytrauma patients. He found that those kids who actually were fixed earlier had decreased ICU and ventilator requirements. This is unlike the adult population, where if you fix them actually very early, they may potentially have greater ventilatory requirements due to acute lung injury, due to the systemic inflammatory response, which we just don't see in kids. And it was actually prolonged immobilization and casting that led to systemic complications in kids. So it's more important to get them mobilized, to be able to be turned, to be able to get up and move around, unlike particularly the adult population. And particularly the kids who had systemic complications were the more severely injured kids who are older, kids who had a modified injury severity score greater than 40 and had an age greater than 7 years of age. So once again, extremely important to get these kids mobilized and moving. It's also important to be aggressive in fixation. I think what ends up happening, just like in the adult population, but when you have a polytrauma patient, traditionally injuries that you may have treated non-operatively may be better served with fixation, so you can get these kids immobilized. So if a kid has bilateral femoral shaft fractures, or has a tibia fracture and a femur fracture on one side, and then has an upper extremity injury, you may actually, in this population, be more aggressive in fixing them so that they can mobilize. If you do have someone who has a displaced clavicle fracture or a very bad proximal humerus fracture, if it was an isolated injury, you still in a regular outpatient setting, you may just treat this non-operatively. But someone who really needs to get mobilized, and you spend all this time fixing their tibia, fixing their pelvis, fixing their femur, you don't want an upper extremity injury to limit their ability to weight bear and mobilize on it, particularly with using crutches, et cetera. So sometimes your paradigm for what you traditionally don't treat operatively in the pediatric population will actually be fixed. So once again, don't simply just have these polytrauma patients come in and cast them. You may be changing your indications due to the nature of the polytrauma, which drives it, rather than the individual fracture pattern. Now, in terms of soft tissue coverage, once again, I think it's important to also understand soft tissue coverage principles, because a lot of times these severely injured patients will have very severe soft tissue injuries. A lot of these injuries, at least in our population, both when I was here in the West Coast, but more I saw a lot of these on the East Coast when I was training, are lawnmower injuries, okay? And that's where a lot of the data comes from. But if you look at lower extremity soft tissue coverage, in general, the principles are, particularly if you're working with a plastic surgeon or you have a microvascular surgeon within your group, kids who are less than 2 years of age, their vessel size is too small. You can't do free flaps. Hopefully, many of these younger kids won't actually have these type of injuries. If they're greater than 2 years of age, actually free flaps do better than adults because they have such a great local systemic healing response. If you can't do a free flap, or you don't have the capability to do a free flap, you can use split thickness skin grafts. You can do rotational flaps with your gastroc and soleus, or you can do cross-leg fasciocutaneous flaps. So I think it's important to know, particularly if you're taking care of a lot of trauma patients, you don't have to ask us to a plastic or a soft tissue coverage surgeon to understand how to do some of these non-free flap choices. And in terms of the outcomes, when you do the free flap with the appropriate indications, there's a very, very high success rate. So it's something that's important to note, that if you have a very difficult soft tissue coverage issue, if you can get someone in who is very comfortable doing this, you can have good outcomes. Another great thing to be able to utilize is wound vac, vacuum assisted closure. If you have these in your facility, it decreases the need for free flaps. A lot of times you can place these vacs on at the time of the initial injury, and it's amazing what it does to the soft tissue. And that can be very, very good in terms of decreasing the need for that. Now, in terms of these open fractures, which goes hand in hand with soft tissue coverage, in general, it's going to be 10% of all polytrauma patients. The infection rates you can see there between type 1 and type 3 definitely increases as you go up in the type. The most important point is that antibiotics and handling the soft tissue is that much more important than time to debridement. Usually when people have open fractures of the hand and forearm, that's typically a low energy mechanism. If they have an open fracture of the femur and tibia, it's a high energy mechanism. So if you have patients who come in with an open femur fracture and general surgery hasn't necessarily seen them, whoever does your trauma service, just make sure you have them actually see them, because even though the kid may look benign, doesn't have any other injuries, that's a high energy mechanism, and that kid may have an occult GI or GU injury, or may have an occult brain injury that you just can't see. So it's important to note that as the orthopedic surgeon, sometimes you need to be calling the trauma surgeons for consultation if they're initially not called in the emergency room. We know that the infection rate in open wounds is really made significantly less with antibiotics. There's obviously the study that was done in LA years ago that really shows that antibiotic treatment is really, really key in terms of decreasing the risk of negative outcomes with open fractures. This is perhaps the main study that gets cited a lot in the pediatric population that looked at 554 open pediatric fractures. They found that if you actually got them to the OR within 6 hours, there's a 3% infection rate. If it was greater than 7 hours, it's 2% infection rate. So the actual time into the OR didn't show a significant difference, but actually the prompt antibiotic administration was the most important factor. So as soon as these pediatric patients hit the emergency room, it's important to let your emergency room colleagues know that antibiotics are the most important thing to get in these kids if it's open fracture. A lot of times the emergency room can be difficult. They're going to get x-rays, they're waiting to call you. Get those, reemphasize to them that it's important to get those antibiotics in, and that's the most important factor. I'm going to spend a little bit of time here talking about pelvic ring fractures, because I think that that's an important part of the pediatric polytrauma patient. Very rarely will kids have isolated pelvic ring injuries just come into the clinic and have those. So a lot of times we're going to see these in the management of the polytrauma patient. And it becomes difficult because it's not a pathology that we see a lot in the pediatric population. And then these kids are going to be critically ill. And then you're making the decision about whether you're going to be taking this patient back to fix them in the context of not really being sure if this is the type of injury that actually needs to get fixed in this age group. So if we look at the epidemiology of pelvic fractures in the pediatric population, it makes about 1 to 2% of all pediatric trauma patients. It's typically due to automobile injuries, and there are a lot of associated injuries in there. So like, as I mentioned before, it's very rare for children to have isolated pelvic ring injuries. They're usually going to have an ipsilateral injury somewhere else. Now, there's some differences in terms of pelvic ring injuries between adults and children, okay? So a single break in the ring will typically occur with kids, unlike a adult patient where you're worried about where's that second break. They have much more elasticity at the sacroiliac joint or the pubic symphysis. They have a decreased mortality rate, as I mentioned before, from these injuries. They have less hemorrhage. And they're typically your lateral compression, anterior posterior injuries. They're typically going to be passengers, and they're going to have decreased pelvic volume and less bleeding. Now, this was a study that was done at USC down in LA here in California, where they looked at all their trauma admissions at USC. They found that the pelvic fracture incidence was 10% in adults and 4.6% in peds. And the injuries that caused pelvic fractures were usually MVC and pedestrian injuries in adults, but falls from heights were much higher in adults compared to the pediatric population. The solid organ injury rate was about same in both groups. And death relating to bleeding was about 2.9% in adults, but there were no deaths in pediatric patients. And the reason why that's important, as I mentioned before, is that pediatric patients don't die from their pelvic injuries. It's other injuries that can potentially lead to that problem. This was one of the first studies that was done by at a Children's Hospital of Philadelphia looking at pediatric pelvic fractures. It was 166 pediatric pelvic fractures, and they basically broke them up into immature groups and mature groups. So in an immature group, they typically had pubic rami and iliac wing isolated injuries. In these immature patients, more of the morbidity and mortality came from the associated injuries. In the skeletal mature group, they had more acetabular fractures, SI joint injuries, or anterior diastasis. And from these skeletal mature patients, it was the pelvic fracture led to most morbidity and mortality. So that's the important thing to note, that even though we're talking about pediatric patients, really that drawing line comes when they are skeletally mature. So when they're skeletally immature in the pelvic ring, that's when you're going to be more worried about the associated injuries. Whereas when they get skeletally mature, it's a pelvic fracture and the risk of hemorrhage, et cetera, that's going to be the more driver of how their outcome is going to be. Now, in terms of the classification, the triradiate status really drives that. The triradiate's closed. The iliac wing is stronger than the pelvic ligaments, and you're getting adult injuries and disruption of the ring. If it's open, then the iliac wing's weaker, and the iliac wing breaks first, and there's no ring disruption of the ring, which is where the difference between pediatric and adult pelvic fractures happened. So in the closed triradiate, there are multiple classification systems. The Young Burgess classification, just like in adult patients, can be used. In pelvic fractures in children, there's this Terode-Zia classification when the triradiate's open, and there's one, and basically divided into 4 different groups: 1, 2, 3, and 4. So for type 1 injuries, they're usually your avulsion injuries, and these are actually the injuries that typically aren't associated with polytrauma. They're these ones that come into our clinic are associated with athletes, and this is typically avulsions, pelvic avulsions, your iliac wing avulsions that can occur from the sartorius or the rectus. Your type 2 injuries are your direct below celiac wings. These are the ones you commonly may see in MVCs, particularly if you're sideswiped, or you see them in patients who are involved in a fall from a height or playing football and get hit very hardly. These are the direct below to the iliac wing. Your type 3 are your simple ring disruptions. So these are typically your pubic rami and pubic symphysis fractures. These are a little bit more of your higher energy injuries. And then your type 4, which are quite uncommon but are quite severe, are your ring disruption injuries. That's where you have bilateral rami fractures, straddle injuries, and sacroiliac joint disruptions. So the treatment, typically for your type 1s and type 2s, if they're hemodynamically stable, you can obviously treat these conservatively. Many of these patients will be hemodynamically stable, and you allow them to weight bear as tolerated. This is much more of an outpatient type management. For your type 3s, if they're hemodynamically stable and their posterior ring is attacked, you allow them to weight bear as tolerated. And really, if you have rowdy children, you really limit their transferring. Your type 4 are the severe injuries, and that's where you worry about the adult type pattern injuries. Once again, this is very rare in the immature patient. You worry about bleeding, as you can see there on the right. So that's the kids you want to really treat aggressively. And then think about those principles that I mentioned before, that you're looking at their heart rate as opposed to their blood pressure to determine if they need fixation or if the pelvic fracture is actually causing severe disruption. And I think that's important because we don't see these injuries that frequently in the pediatric polytrauma setting. It's important to really be heightened if you see this fracture pattern and make sure bleeding is controlled, whether you operate on them or whether you get interventional radiology to embolize vessels that may be bleeding. And besides hemodynamic instability, are there other indications to operate on these patients? And I think 2 centimeters is the rule we typically use, is that if they have more than 2 centimeters displacement, regardless of the age, you need to be operating on them. And there's not much literature on here, but this is one study that looked at 18 patients, and when they had 2 centimeters or greater posterior displacement, there are poor outcomes. There's poor SI joint remodeling in general. The anterior ring remodels a lot more than the posterior SI joint. These patients got leg length discrepancy. They had neurologic deficits. They had chronic low back pain. And so typically for these patients, you do your posterior SI screws and reestablish the anterior ring with plating if necessary, okay? You don't want to use cerclage wires or K wires or pediatric principles. This is where you use adult trauma principles. And if you're not comfortable fixing these ring injuries, you bring your adult trauma colleagues in to help you from an orthopedic standpoint. And we'll end here on acetabular fractures, which once again are another injury you're going to see in the context of a pediatric polytrauma patient. They are generally uncommon. The vast majority of them are non-operative. If they're closed triradiates, then you're going to treat them like adults. But if they're open triradiate injuries, you're going to have special considerations, which I think are important, particularly since these patients will be very sick a lot of times if they're going to have enough of an energy injury to cause an acetabular fracture. Now, if you have fractures to the triradiate, it's important, just like a growth plate anywhere else, you can get growth issues. You can get leg length discrepancy, you can get acetabular growth arrest, and then get subsequent acetabular dysplasia, which you can see here, which is something you need to keep in mind, particularly if there's a remote history of trauma in these patients. In terms of the triradiate injury, if you look at the literature, it's somewhere between less than 1% to 15%. There have been a couple different studies that have shown various results, rates of acetabular growth disturbance, triradiate growth disturbance after acetabular fracture. And the Buchholz study is the one that really has some good pictures and data behind it. And this basically shows that how a triradiate injury can actually lead to acetabular dysplasia. You have the injury, the medial wall of the acetabular thickens, you then develop a shallow acetabulum and then the femur sublux. And from this study, one of the things they said that age is a significant risk factor in the development of post-traumatic acetabular dysplasia. Children younger than 10 years of age at the time of injury are at the greatest risk. And that's important because a lot of times we'll see these injuries and we'll say, oh, you're young, you're going to be fine, don't worry about it. But then suddenly when they're 17 or 18, they come in with a sublux hip or severe acetabular dysplasia that could have potentially been avoided. And you can see there's both shearing mechanisms as well as compression mechanisms that can basically hurt the triradiate. And you can see number one on the left there, there's a shear. Number two, there's compression. Those both hurt the triradiate, regardless of what the initial mechanism will be. The good news is the majorities can be treated non-operatively. You treat them with bed rest, traction, spica cast, and protective mobilization. That being said, if you do have a severe injury with a significant amount of displacement, it may be the need to actually fix these so these kids can get mobilized, particularly if they have multiple other injuries. So the question of when to operate, the indications are when you have joint displacement greater than 2 millimeters, regardless of the age, you have joint incongruity or joint instability, particularly when you have a fracture dislocation. And I think it's important to note that in the context of a polytrauma patient, a lot of times these kids will have injuries and the tendency is for the surgeon to say, look, this is a young patient, this is a very severe injury, I'm not comfortable with it, they're going to be fine. But then subsequently, then 5 to 6 years later is when you see the negative effects of this happening. And it's important to note that growth disturbances can still occur even after non-operative intervention. So even if you don't fix these patients, it's important to follow them over a period of time because they can subsequently then have acetabular dysplasia as a result. And if you do have growth disturbances with these kind of injuries, you can do Physeal Bar Excisions or you can do a pelvic osteotomy in the future. And the reason why I bring this up for this rare injury is that the consequences are going to be quite severe. So if a patient does have an acetabular fracture, it's important to watch them over a period of time rather than simply discharge and then tell them to come back when they have discomfort because they're subsequently doing fine. So in terms of the excision, Physeal Bar Excision, it's premature physeal closure. You can do a Physeal Bar Excision, and this once again demonstrates that. There's evidence of physeal closure. You do the Physeal Bar Excision, you interpose bone wax, but even still, the triradiate's still open at age 10, but they do subsequently then develop some degree of dysplasia. So once again, it's important to follow these patients, particularly the polytrauma patients who may disappear because they come from far away if they have an acetabular injury. So in terms of the treatment of these growth disturbances that may occur with high energy acetabular injuries, small physeal bars are amenable to excision. The premature closure of the triradiate still occurs. You want to recognize and treat these early so that you don't have problems down the road. And you need to even watch these very non-displaced fractures for growth disturbance in the future because they can subsequently give you larger problems as an adult. And the salvage procedures, very minimal literature on this. We don't know. There's some case reports, and there are large pelvic reconstructive procedures that need to be done, potentially if patients are having symptoms. So in terms of the pelvic fractures, which once again is an entity that you'll see a lot of in the polytrauma population, the majority are treated non-operatively. The pelvic fracture is not what necessarily leads to more mortality. It's the associated injury as well. But it's important to note that even though these are kids, this is one injury remodeling potential is quite poor. And using 2 centimeters is really, really key. And the triradiate injury can lead to growth disturbance. Now, in conclusion, as we've kind of done through a whirlwind of pediatric polytrauma and pelvic and acetabular fractures, it's important to note that pediatric polytrauma is at epidemic levels. There are a lot of these injuries occurring, and kids are presenting with higher and higher energy injuries. Almost 3/4 of polytrauma patients will have orthopedic injuries, so it's important for us to aggressively manage these patients and to understand that we will be involved in their care. We have to recognize the differences in pediatric and adult presentation, particularly from a systemic standpoint, and understand that neurologic injury is the most important long-term predictor of how these kids will do, although the orthopedic fixation will help them mobilize and have better outcomes on that path to recovery. In terms of the initial assessment, you want to watch their heart rate, not necessarily their blood pressure. You want to check their cervical spine in terms of how you're mobilizing them. You have to understand there can be spinal cord abnormality without any radiographic abnormality. And you want to place traction pins in the distal femur and not in the proximal tibia. Adults will have 48 to 72 hours where they'll have their organ failure. In children, they'll have immediate organ failure. There's simultaneous organ failure in children versus sequential, and their higher rate of this multi-system failure in adults. In pediatric patients will have a low systemic, high local inflammatory response, unlike adults who have a high systemic and poor local inflammatory response. This allows for very good soft tissue repair at the local level in pediatric patients without the multi-system organ side effects. As a result, in polytrauma patients, we need to be aggressive and early in our fixation, not necessarily treat each of these injuries in isolation non-operatively, which we may do in the outpatient setting. And it's important to note that more research is needed. In terms of open fractures, antibiotics are the most important in terms of treating these. Getting antibiotics in quickly and rapidly will prevent complications. And then surgical timing is important, but not necessarily important as the antibiotic administration. If these patients do come with pelvic fractures, which you're going to see definitely in the polytrauma population, greater than 2 centimeters displacement is your key for operative fixation. And if these patients do have triradiate injury or have an S-tabular fracture, it's important to watch for growth disturbance as they get older. Thank you once again for having me, and hopefully that gives you some pediatric polytrauma concepts to help treat your patients if you see them in your setting.
Thank you, Nirav. Fantastic presentation as usual. I mean, there's a lot of information in this talk.
Yes.
So just a few questions. Nirav, there is in the pediatric setting, I think there is a separate ATLS, like pediatric ALS, right?
Right.
And also there is a lot of emphasis on getting intraosseous infusion. For example, if you can't secure IV lines and you can give intraosseous. So till what age can we give an intraosseous?
That's a great question. Typically, I think most of the literature says, up until 6 to 8, is kind of that time frame. I think after that, the ability for the bones to be able to actually, mobilize that fluid becomes limited. So I think that, kind of under 8 was generally that as well too. And I think that's an excellent point. Is that if you can't get access, going right into the bone is a great way for them to be able to actually get resuscitated.
And the other one is antibiotics. Like you said, there's a lot of emphasis on early antibiotic. Like initially, a few years ago, it was more of early Debrima. And now there's a lot of emphasis on early antibiotic. Like I remember the paper written by Madhav Karnakar from North Carolina, where he made a 66-minute cutoff. And he found that antibiotics given prior to 6, that's quite an odd number to remember.
Right, yeah.
66 minutes, and he found that there's a huge difference in the rate of infection, isn't it?
Right. Yeah, and I think that's key. I mean, I agree. Even early on my training, and I, this is even from 10 years ago, it was all about open fracture, call the OR, get them up there right away. And really, we found that I think 2 points. Number one, the antibiotics are key. And number two, it's also important to be doing the operation at a time which is ideal for the surgeon as well too. And I think the trend, at least here in the United States, in terms of trauma, operating in the middle of the night for injuries, we know the outcomes are poor. Surgeons tired, you don't have the right staff. So I think it's a combination of the antibiotics treating with the infection and also optimizing when the surgeon and the team are going to be are going to be best suited. So I think now the trend is definitely, except for your type 3 injuries, your type 1s and type 2s, as long as they're hemodynamically and neurovascularly stable, get antibiotics in and then do them as the first case in the morning when you're optimized in terms of your outcomes, and then it can really get a good procedure for them. Yeah.
Thank you, Nirav, for that. Just one last question before we wind up the session. And you mentioned about the triradiate cartilage injury, right? So it is sometimes very difficult for a plain ordinary orthopedic surgeon to pick a triradiate cartilage injury. So can you give us some clues? I mean, what are obvious is fine. I mean, an obvious acetabular fracture wouldn't anyone miss, but otherwise there are subtle signs if you miss, and also the Physeal Bar Excision that you mentioned.
Right. Yeah, absolutely. I think for a lot of these kids, I think if there is an acetabular fracture, I think, obviously it's hard in a younger patient to get an MRI, but I think that if, a lot of these kids may get a CT scan, and if you see a fracture in that in that region, I think that's kind of your indication to watch these kids over time. And some people say, well, how do you know it's happening at, a year or two out from the injury, and you're going to be getting an MRI on an 8-year-old? I think if you're starting to see progressive, some degree of hip pain, which you wouldn't necessarily see in that age group, if a kid gets asked to have their fracture at age 8, and then like they come in at 9 or 10 and they're having pain with rotation, which is not a typical complaint, that's where you have to get worried about it. And I almost think CT scanning is a more appropriate thing potentially to get than an MRI, because anyone who has an acetabular fracture is going to have post-traumatic deformity, and I think it's labral tears, et cetera. So then it can be very difficult to say, is this the labral tear? And then someone gets sent down the route of hip arthroscopy, as opposed to this is more due to early dysplasia. So I think CT scans and seeing pain after the injury, which you wouldn't typically expect in those population. But it is hard if you do then subsequently see a triradiate cartilage injury and doing a Physeal bar. It sounds very nice and clean in these papers over here. But even when you do a Physeal bar excisions in a femur or a tibia, it's a very challenging operation to even identify the bar and get them, and then to open up someone's acetabulum and doing it. So I think that, I think most surgeons, what they would probably do, even here in the US, would be if someone has a triradiate injury, rather than doing a Physeal bar excision, which is very technically challenging, is waiting until they're mature and then doing a pelvic osteotomy. Maybe easier to do and more predictable than doing a surgery and kind of violating all the tissue planes for a Physeal bar. But for the few people in the US who do it, then I think it's a good operation. But I agree, it's a very difficult area to get to and then to address, surgically.
Thank you, Nirav. I think that's all the questions that we have for this session. Fantastic lecture, a lot of information here. I'm sure this is going to reach a lot of people all over the world. So thank you so much for joining in, Nirav.
Great. Thank you for having me again. Appreciate it.
Bye.